node, which otherwise is supposed to be oblong, becomes due to central necrosis. It grows in all directions. There's usually a hypoechoic area in the center, which is the necrosis. The fatty hilum is lost, and the halo sign, as you all know, would be that the extra capsular spread can be detected using that sign. So ultrasound can give you a fairly good idea of whether the nodes are metastatic or not. And you can resort to ultrasound-guided FNAC or core biopsy if required. Now, that helps in actually assessing the axilla even before you think about addressing it, because if you can, it can, before you think about sentinel node biopsy or dissection. Now, if it is ultrasound negative, clear negative that is, now, then you can resort to sentinel node biopsy, and sentinel node biopsy picks up the first node of the sentinel means a guard. So the first node is tested, or a couple of nodes actually. It's usually 1 to 3 nodes. They are sent for frozen or imprint, and if they're positive, then one goes ahead and does the axilla. Again, there is a controversy with the ETHealthworld trial that came recently, which has got its own problems, and also the Rose trial, whether you can treat it by simply radiation or you can resort to surgery. That's controversial. But the take-home should be that the positive axilla should be addressed by surgery. Whether you go up to level 3 or not, it's also again controversial. In the absence of level 1 being involved, the chances of level 3 being positive are less than 1 to 2%. So one doesn't feel the necessity, and then the technique of doing axillary dissection can also contribute to the lymphedema. And you see, the lymphedema doesn't show up immediately in the immediate few months or years. So one would feel that the axillary dissections don't really produce that kind of a morbidity. But one needs to follow these patients up for a longer time to know that they do develop lymphedema, and these rates could range from 10 to 15%. In some studies, they're even higher. And that is a morbid thing. And adding radiations once you've done the axillary dissection would actually add to the insult to the injury, because that will add to the lymphedema rates, and it's very, very morbid. So effectively, it should be one of the two, either or the other one. It has been observed in Rose trial that radiation and surgery, because that did not prove radiation superior, but have slightly less morbidity in terms of the lymphedema, but the immediate rates were different. Well, I'm not getting into those trials, they had their own issues. But by and large, broadly speaking, V11 was recommending with 1 to 3 nodes being positive, one can spare the axilla in good patients. That is elderly, ERPR positive small tumors. But the trial had its own problems, that it was non-inferiority. The accrual ended much earlier. They trained at 1,900 patients to finish with 1,300. The centers were too many, and actually eventually it came down to maybe a couple of patients for one center. And then those patients that were in the left alone arm also received the radiation, which was tangential, tangential radiation with the chest wall, which actually meant level 1 and 2 were covered. So there were too many problems, and some patients did receive chemotherapy, one didn't know what was working. So effectively, by and large, the take-home should be that positive axilla in sentinel node biopsy, as of now, most people would like to dissect it, and the extent of dissection would go beyond level 2 for those. There's no level 1 specificity. Having said that, in an Indian scenario, it would need to be a burden being higher, we need to go up to level 3. And if you're doing axillary dissections, you make sure that you clear it out well. Upper limit is actually weighing, the middle limit is also again, but flat limit is flexor dorsal tendon, and lower limit is angular weight. We are aware of these techniques, and we preserve the intercostal brachial nerves wherever we can in order to get a minimal damage to the lymphatic vessel draining the arm. The other thing is, when you're doing breast conservation surgery, the specimen must be oriented nicely, adequately, and most people stick to short superior, long lateral, and putting a clip in the deeper surface for the pathologist to make out which margin is positive. Now, how do you actually ensure and assure quality assurance in X-ray surgery is also important. What are the quality objectives and what outcome measures you look at? The quality objectives are to increase the non-operative diagnosis of axillary nodal metastasis, and the measure would be to get a preoperative ultrasound scan with or without FNA or core needle biopsy. The second objective would be to reduce morbidity of axillary surgery, and that would mean that you do sentinel biopsy with ultrasound negative early breast cancer to sum it up actually. And if you're looking at ensuring adequate surgical staging, sentinel biopsy is fine. Axillary node dissection is another option for staging the axilla. However, most people in an N0 axilla would not resort to axillary dissection or as a standard of care. And now about the options being available, no axillary sampling or doing 4-node targeted sampling. Now, sentinel biopsy doesn't necessarily mean you need to have the dual method all the time, which is considered superior, that is using the dye and isotope both. But if you don't have it, dye alone is also reasonably effective, and one can refer to our own publication with dye alone method, where we found the false negative rates could drop to less than 10%. The ideal aim to achieve to be less than 5 to 7% is an ideal scenario. Therefore, you need to validate with at least 30 cases that should be done. Now, as far as sentinel biopsy is concerned, this validation is mandatory. Accuracy rates should be more than 90%, and we generally take out 1 to 3 nodes, but most people feel that from 1, 2 to 3 to 4, it keeps on improving the accuracy, which is not no rocket science. Which you have more nodes, more likely that you pick it up, and you need to target it to your own patient and your own scenario. Now, should sentinel biopsy in breast cancer be the standard of care in India? The answer is yes and no. We are a land of paradoxes, as I mentioned in the beginning. There are centers where it will be possible, feasible, and it should be offered. At the same time, it will not be possible. So each surgeon who is practicing breast surgery must be trained into doing a good axillary dissection regardless. Even if you find that sentinel biopsy technique you'll pick up, it is mandatory that you should be trained into doing an optimum mastectomy and a proper axillary clearance. Now, what should be the objective when you're managing? Say you're doing mastectomy, minimize chest wall recurrence after mastectomy. It should be less than 10% in 10 years at least in the center, and we should be doing adequate surgery to be able to do that. And having done the surgery, it is important to prevent complications and to reduce the morbidity by taking care of certain sequelae like seromas, which form more commonly if you're doing mastectomy rather than breast conservation, although they happen in both. And there are various techniques that have been adopted. We often keep talking about quilting, using internal padding, external padding. We use half suction drains, so minimal suction ensure that it doesn't continue to leak. And there are many other factors which play a role. One doesn't know. It's there are so many variables involved. It's multifactorial. So to pinpoint that cold night, diathermy, or to use half a full suction, we try to utilize all of the factors and looked at the half suction technique in an international animals control trial which we published in 2005. The data has further been collected, and we're looking at sending the fresh data with good observation in terms of reduction in seroma rates. Finally, a word about Indian breast cancer. There are certain observations with a difference. We found in our own study that unlike in the West, where as the age advances, the incidence of breast cancer keeps on increasing, in Indian subcontinent, we have 2 peaks of breast cancer. One is in 40s and the other one is in 60s. And the one that happens in 40s tends to have higher incidence of BRCA1, BRCA2 mutation, CY17 mutation, and we did make their cell lines, 2 primary breast cancer cell lines. One can refer to this on the top end. And then we started doing some studies on cell lines to look at solutions in the petri-dish for looking for sensitivity. Now, the Indian breast cancer is mostly triple negative, and a lot of it is triple negative. I would say mostly, I'm sorry. The incidence is much higher than it is in the West. Triple negative breast cancer is more aggressive than its other counterparts, and it tends to have, since it has no targets to hit, it is also therapeutically an issue, a challenge. It is paradoxically a very good responder to chemotherapy, what is called as triple paradox, but the outcome is not very good. Are all triple negatives bad, and is black totally black, or black is useless or harmful? No, that's not true. There are certain good TNBCs also, and that is beyond the scope of this discussion, right? But by and large, Indian breast cancer, we have higher triple negatives, and since they're at a younger age, the general concept that this started in utero, the time it takes to show up in the aggressiveness of the cancer, it tends to be younger patients have cancer which is mostly familial and generally more aggressive. Now, neoadjuvant chemotherapy is what we practice to use. We've been using it for years now for locally advanced breast cancer, which is our major chunk in Indian subcontinent, although the percentage of locally advanced breast cancer cases is reducing, fortunately for us, but in many centers it still be the major bulk of the work. Now, locally advanced breast cancer is defined as any breast cancer which is T4 with any N and M0, N2 with any T and M0, and also T3 and 1 and beyond that. But it's not metastatic, although potentially metastatic. It is locally advanced and locally aggressive. And a lot of times it requires a treatment which you need for early breast cancer and also for metastatic breast cancer. Being potentially metastatic, it needs a multimodality treatment in the form of neoadjuvant chemotherapy, downstage it, and then try to get a clear margin to do surgery followed up with adjuvant radiation, chemotherapy, and also hormonotherapy to respond to that. Neoadjuvant chemotherapy is actually a therapy that is given for necessitated cutting arm, therapy that is surgery or radiation, and one would vary. One would get from metriamycin to taxane-based chemotherapy, and the various regimes would have to be tailored to that patient and the stage of the patient breast cancer. It will need to be planned and organized in such a way that patient gets a weekly or a 3-weekly gap in between for the bone marrow to recover, and also for the cell cycle to be in the phase when neoadjuvant chemotherapy can be, the chemotherapy can act well. We don't combine therapies generally because it's usually sequential, and we know that sequencing doesn't change the outcome. Now, chemotherapy and hormonotherapy put together would be recommended for the benefit of the younger friends. The chemotherapy acts on rapidly multiplying cells, and hormonotherapy would prevent them from multiplying rapidly, so that can actually make it less effective. And there are various predictors that we worked on, including markers like mismatch repair genes, T-glycoprotein, then include even toxicity.
The PPT is running on, so can you please tell us which slide you are in?
I don't know, I was just speaking now.
Okay.
And I'm just about to finish. Actually, you can come to, okay, I'll tell you which slide it is, if you want to come on the slide. It will be, I was speaking just offhand.
Okay, sure, sir. Please carry on. Thanks.
Yeah, just checking. Don't worry. Okay. This is Indian breast cancer with a difference. I'll tell you the slide number is 38. 38. Hello? Now, hello?
Yeah, please carry on. Thanks.
The Indian breast cancer, that part I already covered, and its distribution, as you see, is bimodal, and you can see that it's in 30s and 40s, and then later it's in 50s and 60s. So 2 peaks, earlier peak, we observed that as a germline BRCA1, BRCA2 mutation that we observed. This is typically a study of the North Indian patients, and that's the observation sharing. We looked at the breast cancer cell lines in these patients, and we found that it's usually a more aggressive kind of cancer. And it was way back in 2005 and 6 when we were too fussy about triple negatives. Now, we of course know, having looked at the archival specimens, we find that they were triple negatives. Now, there are various ways you can assess predict the response to neoadjuvant chemotherapy mismatch repair genes, where we looked at whether they correlate the response and toxicity as a predictor. This was an interesting observation that those patients who had more toxicity, they had better response. Although it looks like common sense, because if you are looking at neoadjuvant chemotherapy and toxicity would also happen due to its effect on the rapidly multiplying normal cells. That can actually indicate the response and effect. Now, finally, to move on to the aspect, can be there's so many biomarkers that we have studied, and we have not yet found one which can actually predict it beautifully or effectively or optimally. We can't really swear by any. So therefore, it is safer, like here you have P-glycoprotein, enzyme receptors, etc. If you look at from the Indian subcontinent point of view, we are basically cancer, which is locally advanced at presentation, which tends to have advanced disease in the form of lymph nodes being large and matted, and most of them actually are potentially metastatic. So we need to treat them with multimodality management, and eventually we will find that it is the team approach which will be required. Now I'll summarize. I also spoke offhand, considering all the aspects which are necessary. Now, early breast cancer, the dominant treatment is surgery. If you diagnose early, surgery can be minimally morbid, and the outcome can be excellent. A patient with breast cancer can live a normal life like anybody else. And like you saw the distribution, we don't need to look at any slide now. The distribution would be mainly the younger patients now, and India is a young country, and we know majority are young people. The breast cancer is also seen in younger patients now, unfortunately. These ladies have to complete many things in their lives. They're still active and actually involved in their family and social life. So they're able to live well and actively, effectively. So breast conservation should be offered to them. Early breast cancer would rarely need the mastectomies that we did in the past, but if you don't have the facility, and if you're in a remote area practicing breast surgery, the option that you and the patient have is to travel to a center where it's feasible or available. Otherwise, the workhorse of surgery, that is modified radical mastectomy, can still be offered. Done well, it can provide you 5-year survival rate of 20 to 25% right on the table, as I said. Beyond this, most patients would require, if you're offering breast conservation, the patient should be counseled into understanding the whole thing. It's not just leave. The point is not to leave a ticking time bomb inside. Don't leave a breast just with the disease inside or half that job. Patient has to receive the complete therapy, which would involve discussing the case in a multidisciplinary team or a tumor board where you have the radiation oncologist, medical oncologist, breast nurses and others giving opinions about what needs to be done in a particular case, so that everybody sticks to the protocol and the therapy is standardized. For every person, every patient, it will need to be standardized. Having said that, we are all aware of the limited radiation facilities that are existing. So when you don't have radiation facility, conservation should be offered. If it is not in the vicinity, it should be offered. If the patient is not likely to follow up, it should be offered. If the patient can't be made into understanding the significance of these follow-ups, one has to be careful. So it's much better offering the best possible treatment in that case also. Coming to locally advanced breast cancer, we need to be looking at the multimodality treatment. Some early locally advanced breast cancers are large operable, which can be treated with a good cosmetic outcome. After neoadjuvant chemotherapy, they can be downsized and downstaged, and we can achieve an outcome which is as good. But most of them would require all modalities to be treated. A separate section that I was looking at was triple negative breast cancer, which is essentially seen in African Americans, and in Indians we found that it's quite high vis-a-vis the rest of the world. And these are very aggressive cancers that are advanced at presentation, and they do respond to chemotherapy very well. You get good PCRs, but the overall outcome is not very good. Having said that, some of them do well also, and we don't need to address this, take out an axilla node just to dissect out the axilla to find out if axilla is positive or not, because that diagnostic axillary dissection is no longer recommended. You don't need it to just prognosticate also, and most of the times, and if it is N0 axilla, one can address it by using sentinel biopsy or axillary sampling. Sentinel biopsy doesn't always need a gamma probe and radioisotope facility. There are Indian solutions to Indian problems in the form of new targeted node sampling and also low axillary sampling that is popularized by Tata Group, where they've very successfully shown that it's a very effective method of addressing the axilla. But by and large, optimum surgery, optimal therapy would be tailored to the patient, to the center, to the treating physician or surgeon. And eventually, the surgeon who's offering it to the patient should be able to take into account all these aspects. Now, with that, I've tried my best to summarize most of the issues. The subsequent adjuvant therapy would depend on what did you observe in the histopathology when you sent it to the pathologist. That is, again, another assurance is needed. You need to have a good dedicated breast pathologist who can actually tell you about the margins, the grade of the tumor, the various finer aspects like lymphovascular invasion, angiogenesis, and the markers, needless to say, ER, PR, HER2 new, and a lot of people like to see Ki-67 now for the proliferation and plan their therapy based on this. Now, margins being positive would indicate surgery, which is, of course, radiation, and when you're doing breast conservation surgery, you can actually assess margins using frozen section or specimen imaging, and eventually you should be able to get a clear margin. The clear margin, that is oncological safety with a good cost basis, is the dream that every breast surgeon should have and the aim that breast surgeon should have and he should offer to the patient wherever feasible. But at the same time, oncological safety takes preference over all the others. Well, thank you very much. I'll be very happy to take any questions.
The first question is from Prerna. She asks, in which cases breast conservation surgery is advisable and in what situation? Hello?
Hello?
Yes. The first question is from Prerna. She asks, in which cases breast conservation surgery is advisable and in what situations there is usually a case for breast reconstruction surgery?
Thank you, Prerna. The first part of the first question, breast conservation surgery, although I've covered it, but I'll repeat it. It is offered to any early breast cancer where the tumor breast tissue is good and the patient is willing for it. Patient understands the flip side of the local recurrence being a little higher. Patient understands that she has to follow up in the outdoors and the breast OPD regularly, and she has to receive radiation and chemotherapy and other therapies at the same time. As long as you can offer good breast cosmesis at the end of the surgery, you should offer it to the patient. Now, reconstruction means a very wide term. Reconstruction could actually mean that you shift a flap from your back, say that's Leschmer's dorsal flap or tram flap or a free flap, DF or gluteal flaps, or there are so many flaps. They all form a part of reconstruction. It can be immediate or delayed. Usually people prefer to complete the treatment and then go for it, but a lot of people take the middle part. That is, they put in an expander in the initial stages after they've done a skin-sparing mastectomy, and in the second stage, after radiation and everything is over, they put in the flap. The disadvantage of putting a flap or closed flap with an implant initially is that detection of recurrence, although it's not difficult, but may be a problem. But importantly, the cosmesis may not be as good after you've subjected the patient to radiation. So, I mean, if you have the flap in place and you subject it to radiation, it can have its problems. So it's controversial whether you should offer it immediately or you should offer it later. Immediate has its advantages in terms of the psychological acceptance and the patient feeling good about it because you lose the breast and you get it back immediately. But radiation can actually spoil the show by damaging the flap in some cases. And if you've used implant along with it, there are other issues that you need to look into. So the first part of the question was about breast conservation should be offered to most early breast cancer patients unless it is a multicentric disease and the patient is not ready for, not in the fit for radiation therapy and the facility is not existing. It should be offered to most.
The next question is from Rashmi. She's asking, with the progress that medical science has made so far, what are the chances of treating breast cancer cases with a better chance to preserve the organ?
I think that I've already answered. I mean, these are all advances only. I mean, if you're thinking about a tablet which will take care of breast cancer, I don't see it happening in near future. What has happened in the advancement is that the surgery is becoming minimally invasive, but the chemotherapy and other therapies are becoming very aggressive. Now, even radiation has become very minimally invasive. They have a very confined radiation, with IMRT conformal radiation being very, very limited. So collateral damage is minimal with radiation. And with surgery, now surgery is becoming a lot of keyhole surgery. But then the chemotherapy has become very aggressive. So you give at one end and you gain at the other. But by and large, it is becoming feasible more and more commonly now. In the West, if you want to hear the situation, because if you want to really look at the future, you look at what is already happening in the West. And many times when I discuss breast cancer with my colleagues, the breast cancer that we observe today and the pattern that we observe today is what was observed in the 60s in US. So same thing will be observed here in India, what you're observing is now. Most patients undergo breast conservation because they're detected through the screening method early. The key is if you get them early, you can offer them breast conservation. So organ preservation is definitely the possibility now, and it's already happening in a major percentage of cases in India also.
Next question is from Pooja. What should be the precautions that a surgeon should follow to minimize the loss of organ while treating a breast cancer patient?
Well, all the precautions you should take adequate. The incision should be planned very well in advance. Even before that, he should discuss the case with he or she, whoever is the surgeon, should discuss the case with the radiation oncologist, medical oncologist, and all those people who are going to be involved in the care. Number two, he should most importantly discuss it with the patient, and he should mark his incisions beforehand, considering the posture of the patient, the sitting, standing, and all those usual surgical precautions should be taken to ensure that we take just about optimum margin and we deconstruct it with a good technique, so the outcome would be good. These are the precautions you can take.
Next question is from Rohit. Have you noticed any peculiarity in breast cancer cases reported in India than in patients of breast cancer in other countries?
Rohit, thank you. I only hope that you were listening to when I was talking about it, our own publication on Indian breast cancer. I'll repeat it for you. In the West, the incidence of breast cancer increases as the age advances, reaching its peak in 60s and 70s. In India, you get one peak in 30s and 40s, and the second one in 60s and 70s. Now, the peak that you get in 60s and 70s has got a very aggressive behavior because it occurs in younger patients, and younger patients getting cancer is usually aggressive cancer, and it tends to have more of triple negative type rather than the elderly patients. So that's one observation. Secondly, most of our patients present with lumps in the West, as I said, due to screening. They are detected as images. So that is a big difference. The management of an image is through an image. You can do image-guided wire localization and just remove that part like you're taking out small lipoma. It's not a major surgery at all. And the entire breast remains as it was. Here, we have to remove larger lumps. And therefore, it's a challenge to reconstruct the breast, which is cosmetically acceptable. So that's a big difference we observe. In fact, lots of them have axillary nodes. Lots of them have large tumors. So that's the difference we observe. And they're younger patients.
Next question is from Preeti. What are some of the major challenges that you have faced so far while trying to preserve the organ while treating a breast cancer patient?
I think, Preeti, this is just a repetition of what I said earlier, and I'm never tired of repeating it. The challenge is to convince the patient and train the patient that it is possible to preserve your breast and yet living the same quality of life and same life. The first question it's a very, very good question that Preeti has asked. First question that the patient will be asking you is, will I live the same duration that I would with removal of my breast, with just a lumpectomy? The answer is, if all treatment is given the way it is given as per the protocol, the answer is yes. But the moment I tell them that there is a slightly higher rate of local recurrence, they immediately ask you a question, why should I get recurrence? And we explain that the disease is multicentric and some in-situ cancers becoming major later on. They said, then I don't want my breast to be there, because a lot of people have been influenced by this Angelina Jolie effect, where simply based on BRCA1, BRCA2 mutation, this was decided the risk being about 18 to 20%. She went for bilateral profile risk reduction mastectomies. But this was a specific scenario in which it was done. It is possible to counsel the patient accordingly. Now, most patients argue that if I don't have breast left behind, then I won't have breast cancer happening there. That's an argument, all right, but to explain to them, the local recurrence is very easily treatable, and it doesn't change the overall outcome. It won't happen that frequently, first of all. And then it's not that if you remove the breast, it will never happen. So it is to be drilled hard into the head of the patient and to be explained properly. But they do have this doubt in their mind. And a lot of many young patients ask for breast to be removed, and some elderly patients want their breast to be preserved, which is paradoxical. But it has happened.
Next question is from Parimita. What are the chances of recurrence of breast cancer in a patient if she has been treated earlier?
Well, that's a copybook question. It will totally depend on if you're given the optimum treatment. It will depend on the stage of the disease. It will depend on the grade of the tumor. It will depend on the age of the patient and the kind of adjuvant therapy that patient has received. Now, but importantly, most of the recurrences would have happened in 2 years. If they don't happen, then the second time they tend to happen is after 10 years, they say. If you can carry on beyond that, the incidence is low. And therefore, patients are kept under very close follow-up for the initial 2 years. Because if they can sail through those 2 years, where we do annual mammography and 3-monthly clinical breast examination, on the contralateral side also, because the other side has 1% chance of getting cancer. So even the contralateral breast, in usual intrauterine carcinoma. The lobular carcinoma, of course, the chance would further increase because it tends to be multicentric and bilateral. So the chances are not very high. I wouldn't like to give a generalization because it will totally depend on the stage of the disease when the patient presented. But a lot of them live well, and some patients are living 20 years and beyond without a recurrence. But as I said, first 2 years to be watched very carefully, then beyond 5 years, and then 10 years. And they usually do